Hi everybody, this is Lisa at El Paso, Texas. I can't believe how fast the semesters are going. Today I'll be presenting a case study of a patient I recently took care of on September 25th at the pediatric primary clinic that I'm precepting at. I'll present the reason the patient and family came to the clinic, the patient history, my assessment, and the plan of care. MR is an 8-year-old male accompanied by his mother and sister who present to the clinic with complaints that MR has been having increased cough and congestion for the past 2 days with the change in seasons. Mother is requesting a new prescription for Vanacoff and albuterol. MR's mother is the primary historian and is deemed reliable. Beginning with my subjective data and the chief complaint by mom, MR has been having increased congestion, cough, wheezing, and shortness of breath for the past 2 days since the weather has changed. In his history of his presenting illness, mother states that MR has had mild nasal congestion, cough, wheezing, and shortness of breath for the past 2 days. She states that it all started as soon as the weather started to change, and that this change in season always affects MR in this way. Mother goes on to say that his symptoms seem to worsen at night, and she has been trying to control his symptoms by giving him albuterol via his nebulizer at home, but that it really hasn't been helping that much. Mother states the patient has been afebrile and there are no other symptoms to report. She says these coughing episodes always occur in the same manner, and in fact they did last winter too a few times. And in the past, she has always controlled these symptoms with Vanacoff and albuterol via nebulizer. In the review of systems, his general appearance, growth is normal, speech is appropriate. There are no concerns regarding his hearing. Nutrition includes a regular diet. Mother verbalizes MR enjoys eating a variety of fruits and vegetables. And despite these coughing episodes at night, mother states MR still has a good sleep pattern in which he averages about 10 hours of sleep per night. Regarding his skin, mother denies any history of rashes or skin abnormalities. Regarding his head, she states there is no history of any head trauma. With his eyes, mother states there's no history of redness, drainage, no vision complications. Regarding his ears, mother states that there's no history of any ear pain, drainage, no recurrent earaches. Regarding his nose, mother states patient has had increased nasal congestion with occasional clear nasal drainage for the past 2 days. Regarding his throat, she states that he does not have any complications when swallowing. There is no history of throat pain. Regarding his endocrine system, mother states that MR does not complain of any excessive thirst or intolerance to heat or cold. Regarding MR's cardiovascular system, she says that there is no history of palpitations, murmurs, or cardiac complications. Regarding MR's respiratory system, mother states patient has had increased cough, wheezing, and shortness of breath for the past 2 days. She says these symptoms worsen at night and that these coughing episodes usually occur with the change in season. She has been giving him albuterol via nebulizer, but that doesn't seem to help that much. Mother goes on to say that MR has never officially been diagnosed with asthma. Regarding his gastrointestinal system, mother denies MR having any recurrent abdominal pain, vomiting, or diarrhea. Regarding his genitourinary system, mother states MR does not have any history of pain or abnormality upon urination, no complications with his kidneys. Regarding his musculoskeletal system, mother states that MR is able to move all extremities equally without complication. Regarding his neurological system, mother states MR does not have any history of any neurological abnormalities, no history of seizures, no abnormal twitching. Regarding his hematologic system, mother denies any bleeding or bruising complications with MR. MR does not have any known drug allergies, and the meds for home that he currently uses is his albuterol, which is 0.083%. It's the 2.5 milligram in 3 ml vial, in which he gets 1 vial via nebulizer every 4 to 6 hours as needed. The last time he took the nebulizer would have been late Monday night, early Tuesday morning, and in which Mother states that he really didn't have any relief with the albuterol treatments. We mentioned that she had come in requesting a prescription for Vanacoff. She has used this in the past to help control coughing and nasal congestion. The last time he had this prescription was last winter season, so she's completely out of it. It is not something that he takes on a regular basis. Regarding his past medical history, MR does not have any past surgical history, no hospitalizations. Regarding his family history, mother and father are separated. Mother states that there are no current medical complications for both the mother or father of MR. However, there is a family history of asthma, MR's paternal grandfather. MR has 1 sibling, a 5-year-old sister, with no medical complications. Social history for MR. MR lives with his mother and sister in a single-level home. Mother and father share custody of both children, and the children spend time with their father on Wednesdays and on the weekends. MR is in the 3rd grade at Loma Verde Elementary, where he states he gets all A's. Mother states MR plays on a baseball team during the summer months and has had no problems, no coughing episodes during this past summer. He's currently not in any sports. However, mother does add that she has never noticed any exercising or playing sports to trigger any of his coughing episodes. Moving on with my objective data for MR and my physical exam. General appearance, MR appears age appropriate. He is able to talk in complete sentences and does not seem breathless. He is relaxed, sitting on the exam table. MR is in no apparent distress. He is quiet but answers questions appropriately. Vital signs are as follows. Temperature 98.0, heart rate is 95, respiratory rate 32, blood pressure is 112/81, and O2 saturations via pulse ox 91% on room air. MR has a current weight of 54 pounds and height is 49 inches. Regarding my assessment of his skin is intact, no rashes are noted, normal turgor without lesions. My assessment of his head is normal cephalic and atraumatic. Hair growth is normal and well distributed around his head. Regarding my assessment of his eyes, conjunctiva is non-injected, sclera anecteric, lids without ptosis, edema or erythema. Extraocular movements are intact. Pupils are equal and round and reactive to light. Red reflex is noted bilaterally and no eye drainage is noted. Regarding my exam of MR's ear, nose, and throat, his tympanic membranes are both shiny and gray with sharp landmarks bilaterally. There is no discharge noted. Mild nasal swelling is noted with scant clear nasal drainage. His bilateral middle turbinates are slightly swollen and can be categorized as a grade 1. He has moist oral mucosa, adequate dental hygiene, and his oral pharynx is without redness or exudate. Tonsils are normal in size. Regarding MR's lymph nodes, there is no tenderness or lymphadenopathy noted. Regarding my assessment of MR's thyroid, there's no thyroid megaly noted. Regarding my exam of his heart, rate is regular, rhythm is also regular, normal S1 and S2 sounds, no murmurs, no gallops, no rubs noted. Regarding my assessment of his lungs, I do hear mild wheezing but noted bilaterally to the upper lobes, especially on the end of expiration. There is a slightly prolonged expiratory phase and an occasional dry cough. No retractions are noted at this time. Regarding my assessment of MR's abdomen is soft without organomegaly, bowel sounds are normal, non-tender without rebound tenderness, no palpable masses are noted, and no abdominal distension. Regarding my assessment of his genitalia, normal external male genitalia is noted. Spine is straight with no lesions. Extremities, peripheral pulses are equal. There is no clubbing, no cyanosis, no edema of the extremities. Capillary refill is less than 2 seconds. Mental status, MR is alert and appropriate for age. My neuro exam of MR, normal reflexes, normal tone, no focal deficits are noted. He is responsive and appropriate. After considering all information gathered from MR's chief complaint, the review of systems, and the physical exam, these are my initial working differentials. Number 1, asthma with an ICD-10 code of J45. However, the diagnosis of asthma can be broken down even further to be more specific. So I'm actually thinking how I can categorize his asthma, either between mild persistent asthma or moderate persistent asthma. The rationale for this differential: in asthma, cough and wheezing occur particularly at night and in the early morning hours, and also can have a seasonal, continuous, or episodic pattern of symptoms, and they are usually associated with allergens or triggers. My second working differential is acute bronchitis with an ICD-10 code of J20.9. In acute bronchitis, there's usually a phase where upper respiratory symptoms precede the development of a dry hacking cough. And number 3, my third working differential for MR is viral pneumonia unspecified with an ICD-10 code of J12.9. This is because in viral pneumonia, there usually is an initial history of mild upper respiratory symptoms, followed with hypoxia and retractions, usually present with wheezing. So after looking at all of my collected data, all of my objective data, my working differentials, I come up with my assessment and my final diagnoses for MR, which is number 1, mild persistent asthma uncomplicated with an ICD-10 code of J45.30, and number 2, nasal congestion with an ICD-10 code of R09.81. The pertinent positives from my subjective data that support my final diagnoses are as follows. Number 1, MR displays increased congestion, cough, wheezing, and shortness of breath times 2 days. Number 2, his symptoms seem to be triggered by a change in season, or in this case, the cold air. Number 3, MR displays cough and wheezing, which is worse during the nighttime hours. Number 4, these episodes are persistent reoccurrences. As Mother stated, that they occurred at least 3 times during the last winter season. And number 5, there is a paternal family history of asthma. Next, my pertinent positives from objective data. Number 1, The patient is able to talk in complete sentences and does not appear to be breathless. This would be, this is indicative of mild persistent asthma, according to Burns et al. 2017. Other prelim positives from my objective data: he has a respiratory rate of 32 with O2 saturations of 91% on room air. Number 3, MR displays mild wheezing noted bilaterally to the upper lobes at end of expiration. Number 4, MR has a prolonged expiratory phase. Number 5, there is an occasional dry cough noted. And number 6, MR currently is not having any respiratory distress with retractions noted, which is also indicative of mild persistent asthma. So regarding my plan for MR, starting with the pharmacological interventions, number 1, we decide to give MR a ×1 respiratory treatment in the office. He is given albuterol 0.083%, which comes in a concentration of 2.5 milligrams and 3 mLs. We give him 1 vial via nebulizer in the office now, and we are going to reassess after the nebulizer treatment is done. We are going to reassess by pulse ox. We're going to look at his respiratory rate, his breathing pattern. We're going to listen to him. And after the treatment is done, we do see that there's decreased wheezing bilaterally in the upper lobes. He is starting to open up more. We hear more bronchi bilaterally. And he continues with no retractions, and respiratory rate is decreased down to 24%. 24. Pulse ox, when we retake it, did go up to 96% on room air. So after our respiratory treatment in the office, after reassessing him, he seems more at ease. He seems to have responded well to this. We decided it's safe to go ahead and send him home with some medications that mom feels comfortable enough to treat him at home. And we are going to send him home with some medications, and then we're going to take a look at him closely in the next few days, want him back in the office, and reassess and see how he's progressing. So MR will be sent home on 3 medications to help control his symptoms. So we are now going to start him on Singulair, the Montelukast. He will get a 5 milligram chewable tablet. We're going to have him take 1 tablet by mouth daily at bedtime. So this is a new prescription. We will continue the albuterol, give him a new prescription for the albuterol. So he will continue on the same dosage, which is the 0.083%. That comes in a 2.5 milligram in 3 ml vial. He will get 1 vial via nebulizer every 4 to 6 hours as needed, with a max of 10 milligrams per day. So again, we are continuing his previous prescription for albuterol. And lastly, we are going to start him on Zyrtec tablets. So actually, mom says she has seen these. She has some of these for her husband for allergies. She has seen this, so she has seen the Zyrtec dissolvable tablets. She's going to get these over the counter. We told her that she's able to give 1 tablet by mouth daily in the morning. So this is to help control his nasal congestion, his runny nose. Those are the pharmacological medications and interventions he will be receiving. Now on to non-pharmacological interventions. We are discussing with mother that it's important to avoid MR's exposure to known allergens or irritants, So examples of this would be tobacco, smoke, pet hair, dust. She needs to be aware of certain allergens or irritants that could possibly irritate him and trigger his coughing episodes. We are also telling her that she needs to control his exposure to the environment to eliminate or reduce offending allergens. So in this case, protecting him better during the change in weather or to cold air. Next, we are discussing with mother so that she can have a better understanding of what medications we are starting MR on now and when and how to use them. So in this case, we are explaining to mother that the singular is being added to help prevent and better control his coughing episodes so that he will not have as many flare-ups, and the albuterol via the nebulizer can be used every 4 to 6 hours as needed for increased coughing and wheezing. In case of an emergency, they can also give MR the same dosage, 1 vial of albuterol via nebulizer every 20 minutes until better. And they can always proceed to the emergency department in case they see that he is not responding well, in case of an emergency, that's where he should go. Next, we are also discussing with mother that she must be able to identify when there is a change in MR symptoms and when to seek emergency care. We are also discussing with mom and the family that it is important to keep an adequate supply of all medications at both homes. Since he spends time equally both at mom's and at father's residences, it's important that there is an adequate supply of his medications, possibly a second nebulizer, and any other appropriate settings. We are also discussing with mom the importance of getting the annual influenza vaccine, that this can actually help to prevent any sickness during the season. It's just a better protection. Mother agrees to get the vaccine for MR at his next follow-up appointment. There also will be a referral to the pediatric pulmonologist here in El Paso, Dr. Larry Tremper, for new onset of asthma. MR, again, has yet to be officially diagnosed, but my preceptor and I do feel that because he's had a history of at least 1 complete season where he's had recurrent flare-ups or coughing episodes, that it's okay to refer him to Dr. Tremper and see what else we need to do to help him get better control of his symptoms. So follow-up for MR will be in 2 days, which will be Thursday, September 27th, to reassess his progress, reassess his breathing effort, auscultation of his lung fields, pulse oximetry. We will decide if further interventions are required at that time, such as a chest x-ray, before the patient proceeds on with the referral to the pediatric pulmonologist, or if peak flow measurements are appropriate. MR's personal best value with the peak flow measurements will be most accurate when his symptoms are under control. So it actually most likely would postpone the peak flow measurements also, or they might be done at the pulmonologist's office. Moving on to the guidelines for this case study in which we came up with our plan of care. The management of care for this patient is in accordance with the stepwise approach for managing asthma in children 5 to 11 years of age, as seen in the 6th edition of Pediatric Primary Care by Burns, Dunn, Brady, Starr, Blosser, and Garzon, published in 2017. Because of MR's history and clinical presentation, he was classified as having mild persistent asthma. MR's physical assessment findings were congruent with the diagnosis of mild persistent asthma because of the following. He displayed wheezing at the end of expiration. There was slight prolongation of expiratory phase. There was no or minimal intercostal retractions. MR displayed normal aeration in all lung fields. And MR was able to talk in sentences. According to Burns et al. In 2017, in primary care settings and emergency departments, the initial presentation is based on the ability to talk in sentences with looking for increased breathlessness or decreased alertness, none of which MR displayed during his presentation to the clinic. Also, further confirmation that MR was classified correctly as mild persistent asthma came from his mother's history of his present illness. MR symptoms were symptoms more than 2 times per week, but less than 1 time per day. Mother stated that his symptoms only got worse at night. MR was already using a short-acting beta-2 agonist, his albuterol via the nebulizer, which was required more than 2 days per week, but not more than once per day. Mother stated that not only that he only used the nebulizer at night. She did not have to give it to him during the day hours. And MR and his family have used his albuterol neb treatments along with Vanacoff, a cough suppressant, nasal decongestant, and expectorant to control his coughing episodes during the change in seasons. Clearly, this seems to not be an effective approach, as these occurrences seem to persist and even worsen. Evidence that MR does need a change in intervention and management. Due to MR's patient classification of asthma as mild persistent, it is appropriate to start therapy in step 2 of the stepwise approach for managing asthma for children aged 5 to 11 years old. The preferred treatment for step 2 is the addition of a low-dose inhaled corticosteroid, or ICS, or the addition of cromolyn or montelukast is also an alternative option, according to Burns et al. 2017. MR was started on montelukast 5 milligrams PO daily at bedtime, and his prescription for albuterol via nebulizer, 1 vial every 4 to 6 hours as needed, which goes along with step 2. So going on with my debriefing of my case presentation, overall, I chose to present this particular clinical case because we had just completed our asthma action plan assignment last week, and this patient was one of the first patients I had seen since. I felt this was a perfect opportunity to try apply my new knowledge of asthma and to see if the stepwise approach for managing asthma can really be applied to the real world. Using this approach as a guide on where to start, things really made more sense. I was able to recognize how much respiratory distress my patient was in according to his history and clinical manifestations. Also, this approach made it very easy to determine what the next step should be in managing his care. I agree with our final diagnoses, the medications we chose to treat him with, and the plan that was devised to him for home and follow-up, and feel confident that his treatment plan and care were determined by evidence-based guidelines for asthma. On points that I could have improved upon with this particular case, I think in the beginning I had a little trouble trying to determine if this patient should be classified as mild persistent asthma or moderate persistent asthma. I had to really go back and look at MR's history, his previous medications, and his clinical manifestations for it to all make sense. With time and experience, I hope to improve my asthma assessment skills and hope to become more comfortable with asthma care guidelines. Next, both my preceptor and I debated if we should send this patient for an outpatient chest x-ray. I think we both automatically thought he's a respiratory patient. It's something that I usually see done in the hospital setting. When our patient showed marked improvement after his albuterol treatment in the clinic, my preceptor opted to give him his prescriptions for home and follow up in 2 days. At that time, it would be determined if further interventions were going to be needed, such as a chest x-ray. I remember from my readings that a chest x-ray is not usually necessary to confirm the diagnosis of asthma, so I agree with the decision on not to proceed with the x-ray at that time. And then finally, one thing that I think I will have a hard time with in the beginning is trying to determine when it is appropriate to refer an asthma patient out to a pediatric pulmonologist or allergist. I want to be the type of clinician that feels competent to care for a basic asthma patient and only refer out when appropriate or medically necessary. But I also do not want to miss any important factors affecting the care of my patients. I think the answer to this question will come with time, experience, and will depend on the guidelines established by the provider that I work with. In the end, I think the treatment plan developed for MR was appropriate and practical for the patient and family. I do think MR will respond appropriately and favorably to his new treatment plan. This concludes my presentation. I hope this information can be of some use to you in the future. Thank you and goodbye.